Glofitamab is a CD20/CD3 bispecific antibody that's now been approved in more than 50 countries globally for the treatment of diffuse large B-cell lymphoma after at least 2 prior treatment lines. And those approvals were based on the 30179 clinical trial, which was published in 2022 in the New England Journal of Medicine. At this meeting, we've updated the results of that clinical trial, focusing particularly on trial outcomes, as well as response outcomes, as well as immune recovery, and also doing some exploratory analysis at particular landmarks in patients who've had a complete remission. We've now followed patients up to about 37 months after involvement in the clinical trial, and so responding patients, of course, we're following for longer. And what we've shown is that most complete responses are retained at the subsequent follow-up time points. For patients who achieve a complete remission, which is about 40% of patients in the clinical trial, about 56% of those patients will retain that complete remission at the 2-year mark. When we look at particular milestones during treatment, we see that that is very consistent. So for patients who are responding to Glofitamab, they usually respond quickly, and they respond at the first response assessment. So we did a landmark analysis at the first response assessment to establish, it's about 3 cycles, to establish whether patients in complete remission at that time point were going to retain their complete remission. And again, when we look over the long term, roughly 60% of patients will retain their complete remission at that cycle 3 landmark analysis. And then when we look at the end of treatment, again, over 60% of patients retain their complete remission if they're in a complete remission at the end of treatment. Glofitamab's unique in the field because it's given as a fixed course therapy. It stops after 12 cycles. So patients want to understand what their outcomes will be. And this data has really helped us understand that. So over half of patients will retain that complete remission. 3/4 of patients will be alive 2 years after achieving a complete remission within the 30179 clinical trial. So I think that's very reassuring. We looked deeper with MRD to establish whether we could track the tumour in patients using the Roche Avenio CAPseq platform. This was an exploratory analysis. We were looking to see whether patients in complete remission were also MRD undetectable using this ctDNA platform. And we showed that over half of patients at the end of treatment who were in a CR also had undetectable ctDNA. There were some patients whose ctDNA detectable result actually became negative in the follow-up period, and I don't have a good explanation for why that is, but we did see that as well. And we saw that generally in the long term, when we saw patients who'd achieved a complete response and MRD negativity, that MRD negativity was retained in the long term for some of those patients in long-term follow-up, kind of emphasizing the point that a very deep ctDNA negative response can be achieved with a fixed course therapy, which is I think where Glofitamab is unique in the DLBCL space. So they were some very important findings. Now, one of the topical issues about the bispecific antibodies that's come up in people's minds since they've come to market is what are the consequences of B-cell depletion? These agents cause very deep depletion of B cells through their on-target effect, not only treating B-cell lymphomas, but also inducing B-cell depletion in the peripheral blood and in tissues during the treatment period. So one of the other things that we did in our presentation is have a look at the consequences of Glofitamab on the immune system during treatment, but also the consequences of stopping treatment because it's a fixed course therapy. We saw absolutely consistent B-cell depletion as expected as an on-target effect during treatment, but good B-cell recovery between 12 and 18 months after discontinuation of Glofitamab. When we looked at IgM and IgG levels, we saw that IgM levels tracked very closely with B-cell recovery, and we saw that IgG levels were generally above the lower limit of normal, both at baseline and then after completion of treatment. And we then saw a general increase in the subsequent months and years after initial Glofitamab treatment. So the lesson here is that a fixed course treatment and stopping a fixed course treatment not only can induce deep and durable remissions in diffuse large B-cell lymphoma, but also gives the patient's immune system an opportunity to recover with good B-cell numbers and also good surrogates for B-cell function, which I think will be important in the long run for other risks that may occur in late, like infection. And finally, we did have a look at late safety outcomes for 30179. Now, in a prospective clinical trial, the rigorous examination of safety up to 90 days after completion of treatment is the norm, and that's what happened in this clinical trial. Beyond that, and for these later follow-up patients, the safety events that were reported were generally only reported if they were severe or severe adverse events and considered related to Glofitamab by the investigator. And we saw just 2 new malignancies, secondary malignancies, which is important in the context of some of the CAR T-cell data where we see secondary malignancies as an issue, but otherwise no change in our understanding of cytokine release syndrome or ICANS in this later data cut.